Thanks, everyone. And I apologize. In sending these messages each time, it's just a cut and paste, but apparently the cut and paste this time clipped the M from .com. That's not a good thing. And so we were going for, instead of Occam's razor, the simplest thing, we were thinking of the fact that Blue Jeans has been threatening to be shut down by Penn for a while. And when I contacted Chris Petro, he said, well, it looks like they may have finally shut it down. And so then we were looking around for other links until we had at least two detectives that came up with the missing M. So thanks to Corinne and to Daniel. And Daniel, do you want to try sharing your screen for your article?
Absolutely.
And we should say we're very grateful to Daniel for being able to present this article. It's very timely. Obviously, working at the intersection of cannabinoids and opioids, the very hot area. Yasmin Hurd been doing this for a while, and this article is, I think, the most recent one that I saw in terms of her path to bring this toward humans, though she has a large R01 to continue this work with lots of different imaging and other kinds of components. So go for it, Daniel.
All right, yeah, exactly. I thought this was a super interesting paper, and first, thanks for organizing this. I think it's very fun to look at clinical papers and clinical trials because I don't have much experience, and it's good to see the types of measures they're looking at. And in particular, I think this is a cool study because it kind of is bridging the gap a little bit between a preclinical paper like what myself and many other people here are doing, and then it quickly went to this sort of small scale trial, and now they're looking at trials with much larger numbers and more mechanistic things. And I thought it was especially interesting because CBD is kind of complex in its mechanism and binding. Um, it was kind of funny to see that not at all addressed in this paper and addressed in a very limited fashion, even in the preclinical way. So it's possible to just find a drug that shows potential and just run with it. So I thought that was kind of cool. And yeah, as Anna Rose said, this is a pretty hot topic. And I think the more we can throw at the opioid crisis, the better. Um, so yeah, so to get started a little bit with background for cannabidiol or CBD, um, Yasmin Hurd had two papers leading up to this this clinical trial. First, in rodents, showing that CBD could reduce reinstatement in self-administering rodents, and that effect lasted 2 weeks. And then in people, she showed that you could administer high doses of CBD safely while the patients were using fentanyl. And CBD, the drug, it appears in the plasma quickly, it peaks at 3 to 4 hours, and has a half-life of close to a day. And in addition to its potential use for opioid use disorder here, there are a huge number of other issues that are also being considered. And epilepsy, I think, has the most evidence behind it. And another part of the reason why I picked this paper is because after the legalization, there's the widespread marketing, I guess you could call it, of CBD. So personally, I kind of roll my eyes at it. But the fact that it does have potential for all these things, I think it obviously warrants further investigation, but I think it also warrants understanding from us as scientists to help educate and understand. And finally, like I touched on, they don't talk about mechanism at all. CBD doesn't, it's not an agonist necessarily of the CB1 or CB2 receptors. I think people talk about it potentially being an allosteric modulator. I saw some potential effects at serotonin receptors. There's there's a formerly orphan receptor, GPR55, that is expressed in the PAG and elsewhere that it could be acting on. So again, as a preclinical person, it was funny to see the mechanism and pathways and plasticity and all this stuff sort of ignored, and just the more essential things, you could argue, taking the lead. So getting into this study specifically, they are comparing CBD versus placebo. There are two doses of CBD, and they correspond to 5 and 10 milligrams per kilogram, which is how, of course, I think about it. They're measuring craving and anxiety, which are, in this case, subjective measures. It's just a test that they hand to the patients, and these are given after either drug or neutral cues. So the neutral scene is a 3-minute nature video, and I question a little bit if that's the most neutral thing. It sounds like the most positive possible thing. And then the alternative is a drug cue, which is a 3-minute video showing drug use and also physical paraphernalia. So this is a small scale study, 42 total participants. They're opioid abstinent, that's important at the time of testing. Composed of men and women. They were able to see some clear sex effects, but they didn't go too far into it as it regards to the CBD effect specifically. And then some other interesting things that I saw in the demographic table. There's a huge table, really. 78% of the participants had intranasal use, and that definitely went against how I picture the most common drug use. The average for these participants was 13 years of use, which seemed quite high just based on my own intuition. And the majority also had co-nicotine use. And this is taken from the supplemental figures, and I think it's a little bit easier of a summary to understand. So there are 3 administrations of CBD on days 1, 2, and 3. There are Q tests on day 1, so that's a short term, sort of immediately after CBD test. There's a 24-hour Q test, and then there's a third Q test 7 days after the third CBD administration. So any questions about that so far? Cool.
I thought I would mention really quickly that that profile of demographic is sort of interesting and maybe different than what we're seeing here. You also notice that it was heavily African American as well, I think, and so I believe it's in the high 70s on snorting as compared to injecting is probably unusual for around here. Kyle or somebody else who's on the call might want to jump in on this, but it's also possible that because they selected people who didn't have other comorbid drug disorders and no other access, in other words, they had some things that led them to this population that is more selective, if you will, and that may have in some way selected for people who are snorting rather than who have moved on to injection. Once people have begun to inject, it's very unusual for them to go back to snorting. So anyway, I thought I'd just throw that in terms of understanding this population and how specific it is or how similar it is to the rest of the population using opioids, which is now, we were discussing this last week in one of our lab meetings, it's heroin use is the thing that people think they're using, but they're also, of course, sometimes getting fentanyl along with it, and that's the reason for the overdoses very often. Okay, I'll stop, but I just wanted to comment on the population. It is a selected population.
Mm-hmm. Yeah.
what's the time that they are abstinent as well? So you just have abstinent, but do you know like weeks or months that they're abstinent?
Yeah, so they were all greater than 1 week, and I forget the exact percentages, but I think it was like half around 1 week, and the rest were several weeks
Yeah,
to
they had,
a
yeah,
month or two.
they had the different tiers. They had some that were a month and some that were more than 3 months. So
Hmm.
it's a somewhat different group. And the other thing about that demographic, maybe before we move on, is that there was something curious about the fact that when they ask about daily use, the average was 10 bags a day
Yeah,
of drug. And yet, and yet, the people were identifying themselves as, some chunk of them as not having used that much recently. So
hmm,
it was a little curious to me. That was curious because that was daily
yeah,
use,
right,
and
right,
how
which
they
seems like
had
a
that much
staggering
daily
amount.
use and
Yeah,
did not have dependence and therefore would not be able to be abstinent. I wasn't clear about that. But anyhow, we can go on.
yeah, no, I agree. That's totally surprising and worth mentioning. Yeah, and yeah, any other questions about this or thoughts? It is also interesting. So these people, I think, um, did not have a recent history of other forms of treatment like methadone. So that's also selecting a very perhaps unique population.
They
Okay,
were not on
so
agonist treatments. Yeah.
correct. Yep. So moving on to the first results figure, this is measuring change in craving from baseline on the y-axis, and it's comparing the neutral cue, the effects of craving on that nature video versus the heroin cue in orange. And again, this is after during session one, immediately after the first CBD administration, session two, 24 hours, and session four, 7 days after CBD. Um, so session one, you see the largest effect. Um, in the placebo-treated patients, you see a huge increase in craving after the heroin cues. And in both doses of the CBD groups, you see decreased craving. And somewhat interestingly, they note, which is kind of unsurprising, you see that in the placebo group, the increase in changing in the increase in craving, excuse me, after the heroin cues goes down over time. So there's some adaptation, there's some um, uh,
I mean, it's good old,
decrease in
yeah, it could
novelty.
be, they call it habituation, but it's a good old extinction paradigm, right? And
Yeah, exactly.
Terry and other people in the lab, we all have noted that there are subgroups of people for whom extinction does occur, even though in general, these cues are sort of resistant to extinction, and that's sort of part of their character. But you have a very context specific situation here where people, are learning that these cues do not result in the arrival of heroin, and
Right.
they are getting a big reduction. You can design around that, and we sort of tried to do that. We can talk about that a little bit later because it does get in the way, as you can see, if you're trying to do a medication assessment, you're going to have a situation where people are learning that the drug cue in your hands does not predict the drug, and you're going to have this reduction. And you can see that if you wanted to carry it out even further, you're going to have sort of a floor effect in terms of being able to determine differences from placebo or between doses, most likely. And so one way to design around it is to have, between groups designs so that everybody's getting treated, but maybe some people are tested at, pick your time one day.
Right.
Some people are tested again later, but the time that they're tested is the first time that they see your cues, so that you
Yeah.
basically have a way of controlling for that and trying to work around the phenomena of extinction, which is actually a variable. As Paul's been studying, and we all have been looking at the fact that it's it's something that might be linked to a certain kind of outcome, that people who have greater persistence of responding and poor extinction, in our hands with cocaine that seems to predict going on to a worse outcome. So, there's heterogeneity within these populations. At any rate, it's worth noting that this is something that if you're going to design a Q study, it's something to take into account, especially if you're trying to evaluate a medication and not just trying to characterize extinction.
Yeah, right. Exactly. And another thing that I observed, and I don't think they mentioned, is that I found it kind of interesting that the neutral cue caused a pretty substantial decrease in craving after the first session, which went away by the last session. Whereas for the high dose of CBD, it truly is pretty neutral at the beginning, but then that seems to increase. And by increase, I mean decrease craving to a certain degree after 7 days. So I'm just kind of curious.
The changes in the neutrals are actually really interesting in terms of these are separate groups, but basically it's interesting to think about what happens to the neutral comparator in some of our paradigms where the neutral comparators are thrown in there in a fast event-related paradigm with a lot of other cues floating around, including drug cues. Possible that if you have a very aroused baseline that something is going to happen to the neutral so that it actually is itself beginning to take on what looks like some arousal or some evocative power, whether that's just by spillover arousal in a sensory way or second order conditioning or you can think about it, but it's important. I mean, it's interesting here because you have this is between groups in terms of placebo, the 400 and the 800, so it is between groups.
Yeah, and it's this test certainly isn't testing anhedonia, but it kind of makes me think in that direction, like if the drug can change responsiveness to more natural, pleasing things, that would be interesting. And that is a secondary measure, they do test some negative affect, so I'll get to that eventually. And then the second primary measure is anxiety, and CBD has been looked at for anxiety quite a bit and has been touted for use in pets and stuff like that. And mirroring the craving, you can see that during the first session, both doses pretty drastically reduce anxiety. And again, it gets a little bit fuzzy in the second session. There's no difference between the CBD groups and placebo, which could be explained purely because the placebo group has decreased. But then the reduction in anxiety reappears after 7 days.
Daniel, do you know, so did they just give one dose of CBD and that's it? Because it says 24 hours after CBD. So they just got one dose? And
they
then
got 3 doses.
Yeah,
they got a dose each day?
Correct. So on day 1, they got a CBD dose, and then the first Q test. Day 2, they got the Q test first, and then the second CBD dose. Day 3, third CBD dose, and then 7 days after that was session 4.
Would that explain what we're seeing in session 2, because they're not getting the dose until after that craving session, right? So the CBD is not going to have any effect, so you wouldn't see any difference. So that actually kind of gives more credence to the effect, whereas in the craving, sorry, this is anxiety here, but in the craving, like there was still an effect in day 2. So does that suggest that CBD isn't really having an effect on craving, but is on anxiety?
Yeah, good question. I think you would argue that 24 hours after even one administration, it should still be on board and having an effect. Um,
It does have a very long half-life for what that's worth, but that's
yeah,
different than knowing whether or not its psychotropic effects are consistent throughout that time period. But one of the reasons they wanted to look at that longer period is sort of to see, if it would have
mm,
persistent effects after just a single dose, similar to some of the things that they had seen in the animal studies. Um,
yeah, exactly. Yeah, and I think to really answer that question, you would just have to have a between um, group test where it the drug cue is novel after 24 hours, and then you could really get at that. Yeah, but that is interesting about whether it's if it's truly acting on anxiety versus the cue, because that preclinical study from the Herd lab just looked at well, it looked at several things, but it only found an effect for the cue-induced reinstatement and not things like acquisition of self-administration and extinction and several other things. So it could be rather specific to the the cue-induced changes. And there is actually, now that I think about it, one of the secondary measures they look at was a take-home test um, of craving, and they didn't see any effects there. So it really does seem to be kind of like the immediate post-cue um, effect that's being altered by CBD. Okay, and then this was mentioned in the text, and the figures are from the supplemental materials, but I thought this was perhaps the most convincing thing. So these are objective measures as opposed to the previous subjective measures. They measured cortisol levels and heart rate, and this is just from session 1. By session 4, the drug cues weren't having the same physiological effects. But you can see on the right of both these figures that the drug cue for the placebo group increases cortisol and increases the heart rate, whereas the CBD groups both decrease cortisol levels and decrease heart rate.
thought that was encouraging too. It was also interesting that there didn't seem to be a clear dose response in the heart rate
Yeah,
cortisol measure. It looked like they look equally good or equally average, whichever you want to say. But
right.
it looks like they may need to expand the dose response curve to figure out if they
Yeah,
have
the sweet spot.
a lower minimum dose that will still do this.
Yeah, yeah, yeah. I hadn't noticed that. Good point. And then they had many other measures that I just listed out on a table for you guys. And you can look through and ask questions if you'd like. I can point out a few things. So I did mention the negative affect, and that's something that I'm interested in for my own research. So the drug cue did produce negative affect during all 3 sessions, but the CBD didn't seem to decrease negative affect, except for the 800 milligram group came very, very close. So perhaps that is something that would appear with a larger sample size. It looked at temperature of the patients, and the CBD did decrease temperature. That kind of, I think, mixes in to the other. I see some chat thing. Newbutson. Okay, sorry, got distracted. But yeah, so temperature was decreased relative to placebo for both CBD groups. There were no changes in many other things like respiration and blood pressure. There were a couple of mild adverse events, and actually more in the placebo group, so nothing serious. As I mentioned, there was no change in the at-home um, Cravings Questionnaire, which is a little bit odd that they suggest is because the effect might be so specific to the cue-induced craving.
I would really hope, I mean, I guess if I were just making hopes, that you would see a benefit for so-called home cues, right? Because lots of things in the patient's home environment have been associated with their drug use. And yes, we have a very specific, set of cues. They did mention, worth noting, that they tried to match it up so that people who were snorters, they gave them intranasal cues, and people who were injectors, they gave them injection cues. But presumably the ones at home, in terms of just a purely conditioning perspective, should have quite a lot of cue strength, right? They should be salient. Patients talk about the difficulty of trying to achieve abstinence when they're right there on their block, in their building, on the floor, where they can still see people looking high, have people still offer a drug, have people be talking drug talk, people on the corner. The place is there's a lot of really salient drug-related cues. So I'm not so sure when they took the ratings. I'm not so sure of some of the details, but I thought it was odd that usually we think of our laboratory as sort of, it's a pale imitation, right, of real life. We do the very best we can, but it is at best a discriminated situation where patients know that, yes, we have drug cues, but they know from the consent form that there's not going to be any drug coming. And if it's that kind of study, and that basically you are in an extinction situation working against time and repetition to try to look at a medication effect and do some screening. But you really would want something to be able to be helpful at home. So I'm not sure what to make of that. I didn't have enough detail there. I'd be happy to hear other people's thoughts about it. Sure, other
Yeah, I'm
people have
curious.
thoughts.
So one comment, I guess, on a preclinical point of view, right? Like, I think a lot of the sort of the points you made early on that I saw that you missed, right, was that cannabidiol, right, is an approved drug, right? So GW Pharma got it approved for epilepsy. So I think, like, while there is a lot of nonsense in the literature that sort of, suggest what its mechanism of action is. If you look at their patents and their publications, you'll find fairly rigorous studies, indicating what they think the mechanism of action is. And there's a line of thought, right, that CBD in particular interacts with a lot of vanilloid receptors, like TRPV1 and 2, and a lot of its mechanism of action, like may have something to do with that. Indication which they got their drug approved, right, which is epilepsy. But still, there's no real evidence that that's exactly what's going on. There is speculation that CBD is a negative allosteric modulator at mu and delta opioid receptor. However, the concentrations they used in the preclinical setting were really high. I think they were 10 micromolar in order to see an effect. And it seems really unclear to me whether or not at an 800 milligram dose, you'd be able to get, that kind of concentration in the brain. It's pretty high, right? But it's a really lipophilic compound, so I would expect almost all of it would be bound. So it's hard to imagine getting 10 micromolar free CBD in interstitial fluid. It seems not easy to imagine. If other people think that differently, I'd be curious to hear. But I mean, what do you think the mechanism of action is?
Somebody else want to weigh in? Okay, to be honest, I don't even have a guess because if it's hitting like half a dozen receptors, then I I'm not sure I even want to speculate.
Well, that's fair, I guess. I mean,
You
is
know,
there any way to like really
um,
study this stuff though, I guess, you know?
I have a comment that everyone's talking about the use of CBD for epilepsy, and it's really been only shown to have efficacy and used in two or three rare types of epilepsy. It's not a main stem drug that's used for mesial temporal sclerosis or specific neocortical epilepsy. It's like Dravet syndrome and Lennox-Gastaut syndrome, and then maybe tuberous sclerosis. And these are all tuberous sclerosis. They see at CHOP because there's a certain Mennonite population. I think it has there's a genetic component to it. So just before we think it's being used in this group where we're not seeing a lot of epilepsy, but part of my practice is where I'm reading a lot of epilepsy scans. Certainly, there's a lot of use of recreational cannabis, but it is not prescribed or used in a physician pharmacologic sense. So let's just when we're using one thing for what. So I get that, but it's not
Yeah,
clinically
not
beneficial.
broadly epilepsy, sure. Yeah.
Yeah, I think Yasmin, was for years trying to get a CBD in everyone's mind, including reviewers, separable from THC, and because the two things obviously co-occur in the leaf, but it was really hard for her to get the compound to study. And in fact, until in humans it was approved for the treatment-resistant forms that Jake's talking about, it was very, very tough. And so it is a very narrow indication in terms of what the FDA has approved it for. But the fact that it is approved and quote unquote safe, then basically it gives you a door to do the more rigorous studies that need to be done. And there's just a bunch of them. And it looks like she has a large NIDA R01 that's, I think it's in its second year, that's going to do quite a few mechanistic kinds of things, which are, as you said, not part of this initial study, which was, pretty much obviously not mechanistic in terms of any of the data that was collected beyond autonomic arousal and the things that are there, respiration, oxygen. But basically, I think there will be more coming. And I'm sure she's not without hypotheses in terms of the way that it acts. In fact, I've heard, some of her talks. She gave a talk at our place once before, and at some point, so she has talked about this, but I didn't go back and look at that to see where mechanistically people are pointing the major arrows.
Yeah, and so one last thing that I thought was mildly interesting, and you can't take away much from a study this small, but there were no relapses in the high dose CBD group compared to 1 and 2 in the placebo group. That's funny, and it will be curious. I'm curious to see if it does have an actual effect on relapses, because that's ultimately the important measure.
Yeah, and it will be interesting to see how that plays out in the clinic with perhaps a slightly less selected population that's a little bit more like the opioid patients that you see that do have co-occurring disorders, because any other disorder beyond nicotine was not allowed. So alcohol, which is really common, not allowed. Even if they were dependent but not currently needing detox, they would have been excluded. So it's a special group, and they could have a history of cannabis dependence but not currently. And so it's a selected group for sure.
Mm-hmm. Oh, and now that you mentioned cannabis, I didn't put this down, but they do actually talk about that. They do mention that they did toxicology tests for THC, and I think they found it in like 5 people in the high CBD dose group.
Yeah, they did.
So,
They gave the numbers, and the numbers were actually small compared to, because they had selected against it, right? They'd selected against people who had a history of cannabis use disorder. So, but that doesn't mean that still people might not use. So the rates of reported cannabis positive urines is actually probably lower than it would be for an opioid population just randomly. So it's it's a special population. It's one study, but you can see that because this area is hot, that it made it into the American Journal with not too much about mechanism and not too much necessarily in the way of dose response, at least to anxiety. It's actually, it's a preliminary kind of study, but because the area is of great interest, it was published. And it's provocative. People need to think about what kinds of studies would you prefer to do, and if you're going to work with cues, how can you work with or work around them? I think Terry has a comment in the chat about other ways of trying to do workarounds, like getting sets of similar cues so that you can still have novelty, but still have that category the next time someone sees the cues. So it's another way. A bit of a hassle, but it's a way to go. In addition to trying to design between groups for different durations of presentations.
Yeah, I would love to hear more about that. I don't know if she can talk right now, but okay.
Sure, I can talk. I have a voice.
You do, for sure. Please chime in.
Go for it.
I mean, the difference between cigarette smokers is, and that's who we ran the study in, is that we can offer them drug afterwards. So we get less habituation to cues.
And that's important. That's very important.
It is important. I forgot to add that little tidbit in there. So we have been able to show that there's a lack of habituation when you can offer the drug. If someone, even if someone saw, I think, 3 sets of cues that were similarly valenced, but different, and were not offered the drug, you'd see a reduction probably in cue.
I think you saw that with the cannabis cohorts in Cure, Terry. Like by the time they got to the 2 weeks out, they for the second presentation of the cues, even if it was a separate set, there was a reduction for people who were on drug or placebo. If I recall,
it was hard to tell. Our sample size had dwindled, and unfortunately, you need, like this study, you can't imagine. I mean, we all who work with humans know that even though it's a relatively small study, this is really, really hard to do, to get an N this size.
Yes.
And so I mean, this was years of work, not just it's just years and years of work. And in that study, we had a 4-year grant, and it just, we didn't have enough people to really see, I think. But we got a lot of great stuff for the first part before they were on drug. But when we compared drug and placebo, it got really muddy. Then we just didn't have a big enough sample size. So that will never be published. We tried.
But it really is interesting to think about the impact of your selection factors on the population, right?
Yep.
Because we've talked about this before, and I don't know if Kyle's on the call, but basically if you take all the cocaine patients who walk in the door, there are several of them that are more in control, have probably a better prognostic picture, but we selected for many years for the people who would be willing to go into the hospital, because that was a way of getting a very controlled setting. And that seemed to be, and it is important for helping with interpretation. So you could at least say that people hadn't recently used, and you knew how many days you could guarantee that they hadn't used since. But it also selected probably for a more severe population, people who don't have as much going on, don't have a job that they're worried about leaving, don't have, and so we had a skewed outcome population, meaning a very high percentage of them have almost all of their urines positive for cocaine. So a simple thing like that, like saying, are you willing to go into the inpatient unit for a week or two, really changes the population quite a bit. So in this case, the admission criteria for this study, I think, did change the population quite a bit by getting rid of the other comorbidities, except for nicotine, and basically, it's a special population with one that is largely snorters, which is that's unusual around here. I think it would be unusual. So that's what you get when you put those other constraints in. You could get, bigger responses, more persistent responses, bigger drug. You don't know. You don't know. I think the most curious thing for me of all was the lack of an impact on the cravings in the home setting. That's curious to me. I think of everything that's in there, it's not a relapse study, and so I can't put much weight on the relapse numbers with these very small sample sizes. But you really do want something that works at home, right? Because people do talk about the fact that they were okay one moment at home, and then the next minute they run into someone, they see something, they think about something, they wake up from a dream, and then they're really off to the races. And so you really would like something that would provide protection against that kind of triggered motivation. So I'm curious about that. And the next time we see Yaz, we'll ask her.
They didn't relapse, so maybe it protected against that. I don't know. You said the placebo group had more relapses?
Yeah, it had 2 relapses compared to 0 in the high dose.
2 out of... sorry.
I forget. I think it's like 13 or so.
The numbers are small, yeah.
Check quickly.
Interesting. Do you know what type? So they were showing snorting cues, so like snorting heroin.
For the people who had that history, and for the people who.
And did they show Did they show those same cues each session?
Yes, I believe so.
I did look, but it seemed to me that they were showing. Maybe I missed it, but it didn't seem to me that they were saying we had 3 sets of equivalent cues. Didn't sound like that, or 2 sets of equivalent cues. It sounded like they just repeated the task again, right?
Yeah.
And by the way, I'll just toss a comment in here, and Terry knows about this too. We talked about it before, and Paul, is that basically it always, sounds encouraging to be able to sort of counterbalance and deal with your order effects in terms of drug versus neutral. But that can also be tricky because sometimes you will get an order effect because obviously the drug cues have a bigger evocative response than neutral. And even now for the person who has drug first, neutral second, that's going to be a different kind of look than people who have neutral first, drug second in terms of that drug neutral difference. So it's an important thing, I think, to recognize that piece is something that also sometime may need to be taken into account or designed around. I mean, we basically went to the extent that we actually accepted an order effect when we had long videos that were multiple minutes long so that we could be sure to have neutral first, then drug uncontaminated, right? So you can't go home again. So once you've actually, seen the drug cues, it's, tricky to go back.
I have a quick question. This is Julie. For the clinical folks on the call, in terms of the rigor and reproducibility of a study like this, where do you think, this was obviously in a pretty, high profile journal. It was clearly, a small study. So do you think, I guess I would just be curious about, Terry mentioned earlier, like that one study will never be published, because of maybe sample size. So what do you think about getting this kind of information out that clearly has, impact sort of in the public domain with everything that's going on? And Anna Rose, you mentioned maybe because of, cannabidiol, if it were some other compound, would it have ever seen the light of day? So I would just be curious if anybody had a comment on that.
Sure, several people could comment. I'll let them comment first. Are you on the call? I was looking for the link when we screwed up the link, we meaning me. So I hope he was able to get the active link with the M and the .com. I just say that
I don't have a perfect answer for you, but I do remember seeing an article recently that there is a journal that's trying to publish like negative results. So I will look that up and see if I can link it in chat. But I think there is a push to do more of this, to have like all of this information out there. But I'll double check. I could be misremembering too.
Well, and I think Julie's asking it flipped around, which is basically this is a little study with some interesting effects that are provocative, but some curiosities. And, would it, if it were not cannabidiol, would it have made it to American Journal? Would it have? Or would it have just been gently rejected with saying, what, we'd feel a lot more confident about this if you replicate in the second cohort. I mean, all these things that Terry says are accurate. It takes a really long time to get even this kind of sample. So it becomes quite challenging to get large samples that with these patients that are run like this with multiple sessions with any kind of entrance criteria, much less the ones that they were using to narrow it down. But it's a modest sample size, and we've seen things in that range, rejected that were in that range with the comment that was basically a sample size comment, And I think we will see more of that because of the interest in reproducibility. So I think people would like to see, of course, everybody would like to see larger samples and within lab replications so that you have your first cohort and then you have another one that confirmed it. And, we've done some of that. Terry did some of that with her DAT findings. It's very confirming and very affirming when you can do that. Does that mean that no preliminary study should ever be published that doesn't have a large sample? I wouldn't go that far. But the question was really more how much did cannabidiol have to do with the fact that this preliminary study made it into this ranking journal, which is a very high-ranking journal.
What is the sample size again? 45?
42. One.
Yeah, I mean, that is actually a pretty good sample size.
Well, that's across 3 groups, though. Yeah.
Well, yeah.
So once you divide it up into 3 groups, now you're down into the teens.
Well, I'd like a naive question in a row. So if we're sort of just like judging it based on the fact that it's cannabidiol, and then we have sort of these imaginary other putative studies that don't make it, is it also? I mean, these people take into consideration the mechanism of action, right? I mean, like CBD seems to have a really low, abuse potential. It's like readily available, right? It's already part of an approved, drug. It's recognized as safe. Is there any like difference, or do they differentiate between like, agents that investigators might be using if they're not as, well studied or clinically
other people
available?
could speak to this who might have actually been reviewers for American Journal. They obviously are interested in things that might have potential application, right? So that they actually are ready for translational steps. But I can say we've had personal experience with, studies that look like they were pretty encouraging, and they said, why have you just given us 1 cohort? If you have more people, can you give us more people? And that was one of our submissions to neuropsychopharmacology. And so, Paul said, okay, and went back and we, pulled in the whole big long cohort and reanalyzed and expanded the sample and ended up going to a different journal, but with a larger sample, which did give us more confidence. So I've been on the receiving end of the comments about modest sample size. It is a reality. For American Journal, it really depends on the era too, right? One of our articles that was, a long time ago was very modest sample sizes way back at the very beginning of Q-reactivity, before very much had been done. And again, it was because it was early and it was new and people were looking for understanding of triggers for drug motivation. And it was an early imaging article. And it did get into AJP, and it's, often cited. But would it now? Well, probably not, because of all the reasons. It's not novel anymore. And still small sample sizes. So all those things sort of weigh together, and you have a group of reviewers that are trying to look for things that might have translational implications for the field. And, I think cannabidiol is intriguing, and I think it will continue to be intriguing for people. And I think you're going to get a lot of mechanism studies out of Yasmin's lab and others. There are other people that are looking at this. But it's not here in this one. Do we have any other comments or questions?
I can make a couple of comments because it's dear to my heart. It was the very first review for the National Academy of Sciences that I did back in the 1970s. And when it was published in 1980, it really, got time on the Today Show and all that stuff because everybody was excited about it. It's clear that since it's so widely used, we ought to be able to learn more. And it's been reviewed intensively at a national level, beyond what we were just talking about here in this, I think, very interesting paper. But the most concerted effort was a program that was established by the state of California with state funds to try to say, what does medical marijuana really do? And this was during the AIDS age, when AIDS was kind of a death warrant. And so everybody was trying to figure out what to do. And so I was on the committee that reviewed the grant proposals. And the fact is that it was frustrating, just like this conversation, because we couldn't fund anything because we were reviewing it according to R01 type criteria, and everything. Well, first of all, they all had to be placebo-controlled. So right off, nobody wanted to be on placebo. And so I think we're kind of stuck with the fact that it's becoming more and more common state by state. And the only thing that I've seen in the literature that's very convincing is, as someone talked about, the infantile epilepsy syndrome. That seems to really work. And since these babies were having almost daily seizures, and now they don't. I mean, the success of the treatment led the FDA to make a decision, but there's nothing like that for compulsive use or so-called addiction.
We'll see if we get there. I mean, I think one of the things that maybe cannabidiol will have maybe a different path than medical marijuana is because for people who can make the distinction, this is the one that doesn't cause intoxicating effects, shouldn't cause impairing effects on driving. It has a lot of differences from THC. So basically, it should maybe have fewer hills to climb, and some of those things that were barriers to understanding the cost-benefit ratio for medical marijuana. I mean, at least that's the hope. But even with that, Chuck, Yasmin had a really tough time making the distinction for people and getting people to understand that this is something different than marijuana and that cannabidiol does not have agonist effect, et cetera, et cetera. It was really, really, really difficult for her. And she's now extremely appreciated, and so is the work, because it is trying to understand what this compound might do differently than the THC compound. So we'll see. It'll be interesting to see. And maybe we'll do a follow-up at some point. If we'll hear from Yasmin about a clinical study with cannabidiol, we'll be sharing it with each other right here in our journal club. We'll ask her. Anybody have any other comments, or should we wind it down since it's a little bit after 4? I know we started a little bit late, but people have their other Zoom calls. to let it rest there for the moment.
Yeah,
Thank you,
I
guys.
think we can wrap
Thank
it
you,
up.
Daniel. We appreciate it.